Thank you so much for the opportunity to present on the role of cardiac biomarkers in the evaluation of dyspnea in pregnancy. My name is Dr. Amy Sarma. I'm a cardiologist at the MGH Women's Heart Health Center program. I have no disclosures today, except to say that this is a topic that really requires further investigation. So I will be presenting on what is known in this topic, but it's really comprised of small observational studies. And so it's very likely that our knowledge in this space will rapidly advance, and that this is just the beginning of what we understand about this topic. And further, I'm going to focus on the established cardiovascular biomarkers, but there are myriad of other novel biomarkers that are currently being investigated and will likely have a more prominent role as we begin to understand these biomarkers further. So just to step back, why might cardiac biomarkers play a role in the management of pregnant women? So the first is because there's actually a significant potential overlap between the signs and symptoms of normal pregnancy and that of potential early cardiovascular decompensation. And as you can see here at the top of the list is the possibility that dyspnea can be normative in pregnancy, but it can also signal early cardiovascular dysfunction. And so understanding the way that cardiac biomarkers behave in pregnancy can enable clinicians, particularly those who are not cardiologists and really the primary clinicians for pregnant women, to distinguish the symptoms of normal pregnancy from that of early cardiovascular disease. Further, there may be a role in following patients with known cardiovascular disease during their pregnancies with cardiac biomarkers. And this may be actually particularly true in the era of COVID-19, where we're trying to minimize in-person care and optimize our ability to virtually care for patients. So to start, I present a case of a 30-year-old woman in her second pregnancy whose history is notable for a unicuspid aortic valve for which she underwent surgical AVR with a bioprosthesis and ascending aortic repair prior to ever becoming pregnant. Her first pregnancy was 2 years prior and was completely uncomplicated. And while we did not have access to the full transthoracic echocardiography images on meeting her, imaging suggested that her prior bioprosthetic valve was actually not stenotic 1 year prior to her current pregnancy. However, at 24 weeks of gestation in her current pregnancy, she developed new exertional dyspnea and presyncope, for which she presented for evaluation. Her initial NT-proBNP was just over 2,700 picograms per milliliter. So how do we interpret this? Given that pregnancy represents a physiologic state characterized by marked increases in circulating plasma volume, along with mild normative cardiac chamber dilation, there have been several studies investigating the behavior of natriuretic peptides in pregnancy. However, as you can see here in these two small studies, BNP actually remains stable throughout the trimesters and generally less than 20 picograms per milliliter, though median concentrations are approximately double as compared to the non-pregnant state. As such, both BNP and NT-proBNP seem to retain their negative predictive value in pregnancy, such that low concentrations continue to be helpful in excluding heart failure. However, the converse may not necessarily be true. So in an observational study of nearly 800 healthy pregnant women, you can see here that BNP rose in late pregnancy in the early postpartum period, even in the absence of clinical or echocardiographic cardiovascular dysfunction. And 6.1% of women actually had values that exceeded 100 picograms per milliliter in the early postpartum period without apparent clinical significance. Thus, while low natriuretic peptide levels in pregnancy can provide reassurance, elevations should merit further investigation, but may not necessarily signify cardiac dysfunction. Further, in line with our understanding of the hemodynamics of the postpartum period, BNP levels appear to return to their baseline values only 6 to 12 weeks postpartum, and elevations may persist for as long as 3 to 6 months among women whose pregnancies are complicated by preeclampsia. Women with congenital heart disease exhibit significantly higher natriuretic peptide levels at all stages of pregnancy as compared to women with structurally normal hearts, as you can see here. And this is particularly true when we stratify women with subaortic ventricular dysfunction as compared to those without subaortic ventricular dysfunction. You can see that having this ventricular dysfunction is accompanied by significantly higher natriuretic peptide levels. And finally, as you can see here, while healthy pregnant women do not see a change in biomarker levels between trimesters, among women with congenital heart disease, women can see an increase between first and third trimesters with respect to natriuretic peptide levels. Nonetheless, natriuretic peptides still retain their negative predictive value among women with congenital heart disease, with 100% negative predictive value for adverse cardiovascular events among women with an BNP value that is less than or equal to 100 picograms per milliliter. The Zahara-2 study similarly found a 96% negative predictive value for NT-proBNP values less than 128 picograms per milliliter at 20 weeks of gestation. Further, NT-proBNP levels exceeding 128 picograms per milliliter was independently predictive of adverse events among women with pre-existing cardiovascular disease. More recently, our colleagues from Brigham and Women's Hospital found that among 184 women with pre-existing cardiovascular disease, those who had BNP values that exceeded the upper limit of normal had a significantly greater risk of experiencing adverse cardiovascular events as compared to those who did not. So an event rate of 43% versus 9%, which was significantly different at a p-value of 0.02. Therefore, longitudinal assessment of natriuretic peptides among women with pre-existing cardiovascular disease may actually be helpful in identifying particularly at-risk women who may merit closer clinical evaluation due to a higher risk for potential adverse cardiovascular events. So going back to our patient, obviously even absent the elevated NT-proBNP values, her initial presentation was quite concerning for prosthetic valve failure. And as you can see here, her transthoracic echocardiogram revealed that her bioprosthesis was significantly stenotic. She actually had also moderate aortic regurgitation and low normal LV function. And interestingly, NT-proBNP correlated pretty well with her pregnancy course. So she was admitted shortly after her initial presentation with heart failure and was diuresed to euvolemia. And you can see her NT-proBNP levels drop in accordance with this. She actually delivered at around 36 weeks of gestation. But in the postpartum period, she experienced a recurrence of heart failure and her NT-proBNP levels increase in this setting. And in light of this, it was decided that she would undergo repeat surgical AVR and ascending aortic repair. And she actually thereafter did quite well in the postpartum period. She followed up 7 weeks later, where you can see her NT-proBNP level was significantly lower than it was during the end of her complicated pregnancy, although it still had not completely normalized at that time. I now want to go to a second case. And so this is a 42-year-old woman who just delivered her first baby, and she had a history of gestational diabetes in that pregnancy, as well as obesity. So she presented to her primary care doctor 2 days after a C-section delivery with nausea, diarrhea, and dyspnea. It was originally felt that her presentation was consistent with a GI illness, and so she was actually treated with intravenous fluids and Zofran, and cardiac biomarkers were not checked. But her dyspnea remained unexplained, and she actually returned 2 days later to the emergency room, now with worsening nausea and new orthopnea, and she was found to be saturating 80% on room air at that time. So her exam was most notable initially for marked heart failure as well as hypertension. And so her initial differential was concerning for peripartum cardiomyopathy, or PPCM, versus pulmonary edema or volume overload in the setting of preeclampsia. And interestingly, her NT-proBNP was modestly elevated at 544 picograms per milliliter. And this really seemed out of proportion to her exam with marked heart failure. Of note, in the context of incident PPCM, NT-proBNP elevates just as it does in the acute presentation of other dilated cardiomyopathies. And further, we believe there's some prognostic value in the initial absolute value, such that women with lower natriuretic peptide levels at presentation have a greater incidence of LV functional recovery at 6 months. So given a suspicion for PPCM, this patient underwent a transthoracic echocardiogram, which excluded this diagnosis. So she had normal biventricular size and function, but she did demonstrate a small pleural effusion. She had systolic blunting of the pulmonary venous Doppler profiles, which was consistent with elevated left atrial pressure. And she also had an elevated RVSP of 45 millimeters of mercury after accounting for RA pressure. And she was therefore given a diagnosis of pulmonary edema in the context of preeclampsia. Now, several small studies have demonstrated elevations in natriuretic peptide levels with preeclampsia as compared with normal pregnancy, and further severity and disease onset seem to matter, so that women with more severe preeclampsia exhibit greater elevations as compared to those with milder disease or normal pregnancy, and also those presenting earlier than 34 weeks of gestation have greater degrees of elevations. Dr. Kaimal will be speaking on preeclampsia next, so I won't go into too much detail here, but this was a recent study that examined women in the context of acute severe preeclampsia presentations. And this study demonstrated that 10% of these women presented with pulmonary edema that was thought to be multifactorial in etiology. While there was a statistically significant difference in RVSP values between those women with normal pregnancies as compared to those with preeclamptic pregnancies, when you look at the actual absolute values, these RVSPs are not particularly elevated and definitely out of proportion with the degree of pulmonary edema that was observed. And further, when they looked at the BNP values, they found that there was actually no statistical difference between women during normal pregnancy as compared to those with preeclamptic pregnancies. And surprisingly, these BMP values are actually quite modest, especially when compared to the prior literature. And so it may be that the BNP is sort of deceptively lower than one might expect from the clinical degree of pulmonary edema that a woman experiences in the acute presentation of preeclampsia, as was observed in the case of our patient, although this really requires further study. So beyond natriuretic peptides, troponin has now also been investigated in the context of pregnancy, though definitely to a lesser extent. And given the shift now in clinical practice to using high sensitivity assays, overall, we really need more studies in order to understand how high sensitivity troponin behaves in normal pregnancy. However, studies to date suggest that median concentrations of high sensitivity troponin remain low in pregnancy. In fact, very low, well below the upper limit of normal and often below the limit of detection for these assays. Further, similar to natriuretic peptides, we see that these troponin levels remain stable throughout the trimesters, although there may be a small increase in the postpartum period, although still well below normative values. So although the sample size for this study was smaller than what is recommended by guidelines to determine the 99th percentile values for biomarkers, the 99th percentile value for high sensitivity troponin I during pregnancy was notably fourfold lower in this study as compared to the non-pregnant population, though this did not necessarily remain true of the postpartum period. Therefore, it's possible that vasodilation in response to plasma volume expansion during pregnancy may lower high sensitivity troponin values. And so we really need more studies to truly understand what a normal high sensitivity troponin is for a pregnant woman. And in the interim, understand that it may be lower than that for the non-pregnant population. However, it's interesting that just as we saw for natriuretic peptides, about 2% of women in this study who had healthy pregnancies still had high sensitivity troponin values that exceeded the 99th percentile established for the non-pregnant population without a apparent clinical complication or myocardial ischemia. And therefore, we don't understand why some women have these elevations and what these elevations may mean. So at MGH, we actually had the opportunity, albeit with a very, very small subset, to look at these values longitudinally in women with healthy pregnancy as compared to prior cross-sectional data. And you can see again here that biomarker levels remain low and stable, at least between first and second trimester, and that there are a good proportion of women that actually have undetectable, meaning below the limit of detection for this assay of high sensitivity troponin I values. And further, we didn't see any correlation between the two biomarkers at either trimester, nor did we find correlations with age, first trimester blood pressure, or for first trimester BMI, albeit in this very small study of overall healthy pregnancies with pretty normative values. In another small study of women within 24 hours of delivery using a high sensitivity troponin T assay, investigators found that 4.3% of women demonstrated elevated troponin levels, which were generally asymptomatic. When women were stratified by high versus low risk, no differences emerged, and further, no differences were appreciated by mode of delivery. Therefore, the question of why some women demonstrate high troponin or natriuretic peptide levels, particularly in the postpartum period, without apparent clinical complication remains, and whether these elevations are predictive of any clinical consequence or later life disease is really unknown. The other hypothesis generating finding from small studies is that high sensitivity troponin I seems to correlate with blood pressure among preeclamptic women. For example, in this study of 40 women, 25% of preeclamptic women had elevations exceeding the upper limit of normal around the time of delivery. High sensitivity troponin I further correlated with peak mean arterial pressure, though clinically evident cardiovascular pathology or myocardial ischemia was still absent. These findings were also described in a second small study, but you can see that the range of values here among this very small subset is still pretty wide. And so we really need further studies to understand why some women exhibit significant elevations, even in the absence of evident myocardial ischemia, and what, if anything, those elevations mean. Finally, there are several novel biomarkers that are currently being investigated, as I mentioned, particularly in the context of preeclampsia and peripartum cardiomyopathy. And these may serve to be more specific markers of disease, potential therapeutic targets, and may have greater prognostic value. There's been a lot of interest in soluble FMS like tyrosine kinase, or sFlt1, and this is released from the placenta and is an antagonist of VEGF and PLGF, which is a pro-angiogenic protein. So as levels of sFlt rise, levels of free PLGF and VEGF decrease. sFlt levels have been demonstrated to be higher in preeclampsia as compared to normal pregnancy, and notably these changes become evident even prior to the onset of clinical disease. In the prognosis study, which was published in the New England Journal of Medicine in 2016, investigators actually found that when they took a ratio of sFlt1 to PLGF, that ratio being low had a high negative predictive value in ruling out preeclampsia in the subsequent week. Within the context of PPCM, high sFlt levels are associated with worse NYHA class and also associated with a higher risk of adverse events. Similarly, soluble endoglin is another placental derived soluble TGF-beta co-receptor that induces vascular permeability and hypertension. And activin A is another secreted TGF-beta family member that is thought to be released by the placenta and is evaluated both in preeclampsia as well as in heart failure. And so all of these markers have been of recent interest. And notably, they've all been correlated with worse global longitudinal strain, which is a marker of systolic dysfunction, as well as left ventricular mass index and postpartum blood pressures following preeclamptic pregnancies. There's also been interest in microRNA 146, which is a downstream mediator of this 16 kilodalton prolactin. And investigators have interest in this because it could be that this is a more specific biomarker for PPCM. So it's elevated in the context of PPCM, but not in the context of acute presentations with other dilated cardiomyopathies. And there's also interest in this as a potential therapeutic target for peripartum cardiomyopathy. So these are just a sample of markers that are currently under investigation, may have further specificity within the context of pregnancy. But for now, I'd like to just propose some of these practical suggestions based on the limited data that I just presented. So in normal pregnancy, I think at present, cardiac biomarkers are probably unlikely to provide additional information in the absence of symptoms. So the utility, I think, of checking them routinely is low. However, among pregnant women with established cardiovascular disease, following longitudinal natriuretic peptide levels in particular may be helpful in stratifying women who may be at higher versus lower likelihood of cardiovascular decompensation. And this is, I think, particularly useful to understand in the context of COVID-19, where there's a desire to minimize in-person evaluations. So understanding that natriuretic peptides retain their high negative predictive value among those even with pre-existing cardiovascular disease, I think is useful. So for example, if you have a pregnant woman who has low normal LV function and she starts to experience mild dyspnea in late pregnancy, a low NT-proBNP may enable you to continue to check in with her virtually, but even a mildly elevated level will probably prompt you to bring her in for in-person investigations. Similarly, even in women without pre-existing cardiovascular disease in whom the etiology of dyspnea seems out of proportion to what might be expected for normative pregnancy, cardiac biomarkers can be further helpful in figuring out who may merit further cardiovascular investigation versus in whom cardiovascular pathology seems less likely. And finally, although we know that some women can experience elevations in both natriuretic peptides as well as high sensitivity troponin, particularly in the postpartum period, and we haven't found obvious clinical significance for these elevations, these women are still really in the minority. And so any biomarker elevations in pregnant women really should prompt further investigation. And this may be particularly true for high sensitivity troponin, given that we suspect that levels in normative pregnancy should be quite low. And in fact, a good number of patients should actually have values that are below the limit of detection, particularly for the troponin I assay. And so there should be a very low threshold for further investigation among women presenting with chest pain, especially given the high morbidity of myocardial ischemia in the context of pregnancy. So thank you very much for this opportunity to present on this topic, and I look forward to any questions.